Hello, and welcome to another episode of Arthritis at Home. Today we feature part two of our discussion and conversation with Dr. Sacha Bhatia. He's a cardiologist and the FM Hill Chair in Health System Solutions at Women's College Hospital in Toronto. And he's looking carefully at digital health innovations and the delivery of virtual care in Canada and health service design to influence policy that will improve the delivery of care to patients across Canada. Dr. Bhatia, thank you for joining us again at Arthritis at Home.
Thanks so much for having me.
For the marginalized, whether it's low income or English as a second language or low health literacy or low digital literacy or no access to technology, these are all barriers that the governments and the healthcare systems, we're going to have to look at very, very carefully. Talk to us a little bit about integration. So what does that look like? Because obviously we get asked the question, we're not experts in technology, we're experts in arthritis, and we're trying to arrive at this intersection. We get asked about integration, and boy, oh boy, there are a lot of serious issues there that have to be addressed and have to be addressed fairly quickly.
Yeah.
And obviously we hope it's not just experts like you, but it's people like us who are also at the table talking about it.
Yeah. So for an arthritis patient, maybe the first time that they see somebody is either in person or on video. Maybe follow-up conversations that are just routine could be done using asynchronous messaging or telephone or maybe video. Difficult conversations like deciding about surgery or deciding about starting a very difficult medication, maybe like a biologic. Maybe those conversations happen in person because those are conversations where there's questions and there needs to be time. The point is not every modality is appropriate for every clinical situation. Our job now, and I always say where we are with virtual care, is we're virtual care 1.0. We figured out the adoption. Great. People know what virtual care is. Now we have to start to refine exactly what modality is clinically appropriate when and with what patient. And then we have to build in all the equity components. So, either we figure out a technological fix to ensure that people who don't speak English first language can use virtual care, designing tools that make it easier for them, or we need to ensure that there's equitable access to the right tools. The point is this is about building a robust system that isn't just about one door for everybody, but the idea is that we have a system that has multiple doors, but that combine in at an integrator site that allow us to ensure that we've got the right care getting to the right person at the right time using the right technology. So that's sort of where it is. It is a long road. I don't think this is going to happen overnight, but I think we're in a good start.
I'm going to ask you just to follow up on that trust in technology, because it raises, I think, another interesting question. But I do want to just go back. For about 1 million of the 6 million people living with arthritis in Canada, they're living with a complex inflammatory arthritis. The therapy and conversation, particularly the advanced therapy conversation, is one that is happening every day and is critical in terms of the care and treatment and recovery, return to life for a lot of our patients. You said, maybe that's one that's best in person, but when you think back to what we were talking about earlier, how that person who is able to have a meeting at home without all the stress of having to go to a doctor's office, I'm wondering if that advanced therapy conversation, we want to talk about starting on a biologic. I wonder if virtually for that person to be at home collected and calm and the notepad and have that list
Yeah.
of questions ready, maybe that's an actually better venue than.
It could very well be, and that's the point. We shouldn't have the technology dictate the strategy.
Yeah.
The point is it's we have I see technology simply as tools. There are ways that we communicate information and we get information from patients, and that needs to be personalized. Like, again, in the same way that if you're at the bank and you want to pay your phone bill, there's many different ways the bank allows you to pay your phone bill depending on your individual circumstance. So, one of the things that we often hear is that, and prior to the pandemic, the truth is we were pretty monolithic. The only way that you got care was physically coming, whether you needed a prescription refilled or lab tests, ordered or reported, or have a conversation with your doctor, is an in-person visit. And that was it. And now when you actually think about it, there's a multiplicity of tools that I think we could unlock. And we haven't even talked, for example, about asynchronous messaging or email, texting, that sort of thing, which, I mean, for patients who are well known to their care team, could be a way to increase capacity tremendously. Because think about all the patients that have arthritis or on biologics or whatever, and they don't necessarily need appointments. They can, if they've got symptoms or questions or concerns, they might be able to email in with a nurse or nurse practitioner in the care team, and really be able to connect and feel very connected to their care team. So the point is, I think the point is valid, that we have to begin to use and unlock the tools that we have to make life easier for our patients. And that might be an in-person visit, but it might be a virtual visit. It might be an asynchronous messaging visit. Like, there's so many possibilities. So I think we should explore what those possibilities could look like.
So just go back in terms of this this leap of faith I think we all have to take with technology, because obviously there are a lot of people who still have a lot of concerns and not really comfortable, uh, sort of with a wholesale adoption of technology. And that is something that you and I have been around for a while, and we know electronic medical health records has been sort of that boogeyman that predates this discussion for decades.
Mhm.
Do you think, and I'll try and keep you to a short answer here, just in terms of maybe pointing us in a direction. Do you think this momentum that has gathered over the last 12 months and the discussions that we are now having at the policy table are going to lead to a dismantling of the barriers of adopting EMR?
I mean, I think EMRs are going to happen across, and they already are. I mean, massive adoptions already, and I think that's just going to continue. I think the more interesting question is, what are we going to unlock and adopt EMRs for? Which is it just going to be a place for notes, or are we going to start using them in proactive ways as integrators of information, of being able to look at data from, think about this, more patients have more data about themselves on their phone or on their watch than I have in my entire hospital record. How are we going to use that and unlock that in a way that can help them? So I would say, I think adoption is one thing, optimization is a totally separate thing, and that's where we need to go.
Thank you. Obviously, a question that you and I could talk about for the next half hour. But this is now marks the end of our interview. Dr. Bhatia, I want to really thank you for joining us today. I would also like to get a commitment from you that you'll join us again, because I think 2021 is going to be a very dynamic year. And certainly as it relates to virtual care and the delivery of care across the provinces in Canada, it's going to be evolving and evolving probably quite dramatically. It's going to be part of this new or next normal. And I hate using the cliche, but it's true.
Yeah,
Um,
I agree.
so thank you very much for joining us. And thank you to our audience. Happy to see you here. And hopefully you can join us again next week for another episode of Arthritis at Home. Thanks, Dr. Bhatia.
Thank you so much.